All right, let's get going. This is 4.2 on drainage pathways. Just a light disclaimer before I get going. I don't need you guys to memorize absolutely every drainage point from every organ, from every region. I'm just giving you guys a good broad perspective here so we can just appreciate the gross anatomy of it all, and that understanding the drainage pathways can really elucidate where infections travel, where cancers travel. But there's a lot to that story, and I'm not trying to overwhelm you. So I'm not having you memorize everything, just disclaimer. Let's get going. All right. Lymph typically follows our vascular supply, right? It's like a secondary circulatory system almost. We have superficial lymphatics and deep lymphatics, and that's exactly what they sound exactly like what they are. The superficial is directly underneath the skin, usually running with those superficial veins, and the deep lymphatics are deeper, running with those deep veins and deep arteries. The superficial nodes will eventually drain into deep nodes, and those deep nodes ultimately drain to the thoracic duct and the right lymphatic duct, both of which drain at their respective venous angles. The right lymphatic duct being the right venous angle, and the thoracic duct being the left. So regions obviously have this preferred drainage pathways. That's what we're going to be discussing today, but a big caveat here is that there's going to be crosstalk. So despite, A going to B and B going to C, there's a non-zero chance that we could get A to C, or, A to X. You know what I'm trying to say? Like, there's a preferred drainage pathway, but really it's just the path of least resistance. So if the body's angled a sort of way, if there's any blockage, if there's any infection, that might change this preferred quote-unquote drainage. So crosstalk is definitely a thing here. However, understanding these drainage paths can be really crucial for tracking infections, right? If a lymph node downstream is swollen, well, that can give you an idea of potentially where the infection is occurring, what tissue space, what organ the infection is occurring in. All right. And just to review for that venous angle, right, there's my left internal jugular vein, left subclavian. So the thoracic duct joins at that left venous angle. So while we're doing these drainage pathways, think, 75% of the lymphatic drainage of the body ultimately has to get back to this thing right here, which I think is pretty cool. We have all of these drainage pathways, but all roads lead to Rome, or at least 75% of them, with the other 25% being there. Okay, so with the scalp and the face, I'm going to throw a lot of anatomical terms. I apologize. Anterior face, lips, eyelids are eventually making their way down to the submandibular region. So that's all of this here, eventually making their way down here. So I'll go ahead and draw some in. You have some lymph nodes kind of underneath your jaw or your mandible and like the angle of your jaw. Then we also have some drainage kind of in the front of the ear. Some parotid nodes hanging out there. Para means nearby. Otid means ear, so nearby the ear. Some posterior cervical nodes back here. Could probably draw in another arrow sweeping down the back of the skull, the occipital region. And then submental, if you want to be super picky. These are pretty small. The mental region is just the point of the chin, so submental underneath the point of the chin. And then perhaps the most important region here, basically all down this line, kind of flanking the internal jugular vein, you have the deep chain of cervical nodes. And that's basically draining everything from the head and the neck. That's one of the ultimate drainage spots of all those nodes. In that deep cervical chain, you have a really big node called the jugulo-digastric node. Try that again. There we go, jugulo-digastric. And I guess we can represent that right around here. So that's going to be near internal jugular vein, kind of hanging off of sternocleidomastoid. And that's just a big collection point in the deep cervical chain where all this drainage is happening. So your tonsils are going to drain into here. you go, right here. Waldeyer's ring is the fancy name for all of the tonsillar tissue. So if we have something like strep or anything that's flaring up the tonsils, well, there's a high likelihood that those nodes on your neck, the jugulo-digastric node specifically, is probably going to be inflamed because that's one of the initial drainage spots of this area. So, pretty cool. Apologies, still under the weather, so I'm not trying to sound gross, but say la vie. Okie day. Next region we'll talk about is the breast. Pretty simple here, honestly. I'm going to keep it surface level. It is a bit more complex than this, but if we're on the lateral aspect of things, well, I'm going to go to the axilla, right? The lateral breast is closest to the armpit, and like we talked about on 4.1, if you have an angle anywhere in the body, there's probably a set of lymph nodes there. So those are your axillary nodes. Oh my gosh, excuse me. Medial quadrant, we're closer to the sternum. These are your parasternal nodes hanging out right here. So basically just what am I closest to? Very anatomy heavy, right? For sentinel nodes, we'll talk about that in a moment. This is the node closest to drainage, or I'm sorry, closest to the infection point. So if infection is occurring near node X, that node's going to get flared up. That would be our sentinel node. So we'll talk about that in a moment. But for the breast, it's usually the axillary node. So this is usually swollen up if there's a malignancy here. For the lungs, it just follows the respiratory tree. Let's see here. I should have had lobar. Let me change that really quick. Oh my gosh, it looks horrible. One more time. There we go. So literally just following the respiratory tree. Pulmonary, I mean like the alveolar level. So all the way down at the grapes. And then you have bronchi going to the lobes. So hence lobar. And then tracheobronchial. So those are your big bronchi right here that go to the lungs right and left. And then your trachea is right here. So you'd have nodes along that whole stretch. And then paratracheal next to the trachea. And maybe some bronchomediastinal just in this whole general area. So again, I don't need the whole memorization here. What I'm after is the fact that it just runs the whole respiratory tree. And we need it to do so, right? You are breathing in air that constantly has particulate matter in it, constantly has germs, pathogens, any, dissolved particles, any aerosols. We want really good surveillance here, right? Think back to the transplant talk. That's why lungs are the most failed transplanted organ because of the high, immune profile here. So having good lymphatic supply also is another advent of that. And to a lesser degree, we have the heart and the pericardium, also covered by these tracheobronchial nodes here, because they're right near the heart, right here. Cool. Okay. So my abdomen, we can split that up into the foregut, midgut, and the hindgut. I have the definitions of those there. I guess I didn't include the hindgut. Super cool. That is the rest of the large intestine. So let's go distal third. And the rectum. Okay. All I'm really concerned with here is this cool ultimate destination. So the foregut, dealing with the celiac nodes, that's near the celiac trunk, which is the artery that supplies the entirety of the foregut, making their way to the intestinal trunk, dumping in the cisterna chyli. With the midgut, Same kind of deal. Superior mesenteric nodes, superior mesenteric artery supplies the midgut. Drain to the intestinal trunk and to cisterna chyli. Hindgut, supplied by the inferior mesenteric artery, goes to those nodes. Those nodes drain into the left lumbar nodes and then make their way to the cisterna chyli. So I yanked this picture from Google, but this really does just bring it all together. I don't need you guys to know all of these by no means, but what I'm concerned about is just that we have this central point here, this cool all roads lead to Rome a concept that I'm after. Gosh, I cannot think today. So you can track all of these if you want. I'm not asking for all of that, but what I'm after is that we eventually make our way to these intestinal trunks, and that drains into the cisterna chyli, which is that pit at the almost the center of your abdomen, and that directly drains into the thoracic duct, which makes its way up to the left venous angle for the ultimate drainage point. All right. Now, remember, the lymph here is technically, we're going to call chyle, CH, not Kyle. Chyle. That is a more fatty and opaque version of lymph. Why? If you don't know, go check 4.1, but we have those lacteals within the gut that is accepting the chylomicrons, which are too big to be absorbed into the blood. So that's how we get our fat back into circulation. And remember, fat's not inherently bad. It's good to have for cholesterol, for cellular membranes, many other reasons. So we need that absorbed somehow, but it's too big. So we throw it into the chyle, and then that makes its way back into the cardiovascular system through lymphatics. All right. Yeah, a lot on this page. Take it lightly. Take it lightly. A couple of things I'm after is just noticing some of the similarities between male and women, between men and women, perfect, and just noticing that it's not simple, right? Everything external doesn't simply drain to your inguinal region, and even the internal structures have variance here. So that's just what I'm after, just understanding that there's variability here. Why is there variability? Why can it be easy? Well, we're not simple creatures, and also, if anything's complex and confusing in anatomy, my instructor taught me, well, we blame embryology, and we can do that here for sure. So let's do a light little overview here. So the fundus of the uterus is the top, this blue region here. Also, the ovaries are contained in this drainage pathway as well. That's going to go to your lumbar nodes. We have external iliac and internal iliac from yellow and green here. Your iliac nodes are close to that inguinal region, like the hip region. And again, we have this idea of crosstalk. So some of this drainage will go to the superficial inguinal nodes. Let's see. Let me define that really quick for you guys. Inguinal is this right here. So it's just the junction point of my lower limb to my trunk. Okay. So at first glance, you might think, well, all of that genitalia, all of this genito-repro stuff should just drain right there. But no, it has a lot of different drainage pathways because a lot of that stuff does, go internal and has to deal with a lot of the lymphatics inside. In terms of the vagina, we have the internal and external iliacs, so that's more the deeper structures here. And the lower third is more so that's superficial inguinal, so more so the skin region of it all will drain into the more superficial region, right? Because that makes the most sense. And labia and clitoris. So the cool thing here, the clitoris right here, the deep inguinal node will receive that drainage point. So that's weird, that's a very external structure, but the drainage for it is very deep. I don't have the explanation for why. There's probably some weird embryological reason. But what is really cool here is that this shows us that the clitoris and the glands of the penis are homologs with one another because they both have the same drainage pathway. So really cool, kind of showing some interconnectedness there. Okay, now on to the male, the testes, more of a lumbar drainage pathway here. So that light blue. Now, why would something, dangling between the legs have drainage pathway, a drainage pathway that's similar to my kidneys, right? Well, because you might have heard the testes have to descend. They are usually, or they begin up here. And then a fun embryological thing called the gubernaculum. The gubernaculum, it's a strap of connective tissue. As development occurs, that gubernaculum shortens and yoinks those testes down into the scrotum. Okay? But that's where they started. They started in the lumbar region, hence that lumbar drainage pathway. So, a cool thing there. Again, if it's very superficial, think about skin, think about the entry point to the vagina. That is going to be a very superficial drainage pathway. So those superficial inguinal nodes are going to get that drainage. Same with most of the shaft of the penis. But again, the glans is a different drainage point due to how the external genitalia is formed. And that's conserved between men and between women and men. Gosh. All right. And then the prostate also, internal iliac. So these iliacs are more so for those internal structures where the internal and external iliac arteries and veins are, if you know. But yeah, that'll drain those internal structures here. So green for internal iliac, and there's that prostate there. All right, so yeah, very complex here. I'm not going to have you label all of this, just appreciating that there's a high level of complexity and difference in drainage here. And where the similarities lie is also interesting as well. Even with testes and ovaries, right? Those are also homologs with one another. So the fact that they share this lymphatic drainage does make sense. All right, way better. So that was the meat of it. Okay, so I think we're in the easy point now. The extremities, super easy, right? If there's an angle, there's lymph nodes. There's an angle, there's lymph nodes. So arm, cubital nodes. Cubital means elbow, axillary means armpit. So that's the drainage pathway there. And then we just go right to the angle that we're near. For the leg, we have popliteal nodes, and those typically drain into those inguinal nodes. Inguinal nodes will drain into either you have like external iliacs or internal iliacs, maybe some lumbar here, but we're ultimately getting to that cisterna chyli, that central pit in the abdomen. All right. Something to think about here is just the superficial versus deep drainage. Ultimately, superficial drainage will go to deep drainage, right? Because eventually we have to make it to the cisterna chyli and then up this thoracic duct. So eventually these nodes will drain into these deep nodes. Yeah, so the limbs are pretty simple. We just get to a joint and just continue all the way up. All right. Oops. Yep, last slide. Cool. So just some clinical nodes. I think this is a cool concept. It's one of the reasons I made this lecture, the idea of the sentinel node. So it's the first node to receive the lymphatic spread of a primary tumor or whatever is infecting us, right? Usually identified by dye or some sort of radioactive tracer, so we can, really section out where this malignancy traveled, and then you can do something called a sentinel node biopsy, or just removing the sentinel node in general. But we can take a biopsy, we can take a sample of the sentinel node and gauge it for what does this malignancy look like, and how can we best treat it. Okay. So typically for like breast cancer, the axillary nodes are going to be the sentinel nodes. Now, like I said, I didn't go super in-depth. We can subdivide the axillary nodes into different groups as well, but I didn't want to do that to you guys. But even like something like the penile glands carcinoma, like this is why understanding that lymphatic drainage is not as intuitive as you might think is really important, because a really unfortunate site for cancer, yes, but also understanding that, well, that drainage pathway is very, very deep, despite that structure being very external in nature. So really, really cool concept, understanding the sentinel node idea that really does allow us to understand where infections travel and where malignancy is likely to crop up depending on the site of an initial infection. And perhaps the best example of this, but it's a little morbid, I'll give you, is Virchow's node or Trossier's sign. So the left supraclavicular region here, so my left interjugular vein would be here, and my left subclavian vein would be right here. So if you've been paying attention, you know that your thoracic duct will be draining right here. Well, right before that thoracic duct meets with the venous angle, we have a chunk of nodes. All right, sometimes called Virchow's node, but if we want to just keep it simple, it's the left supraclavicular nodes, right around here. The final filter, the final sieve, the final checkpoint before dumping back into venous, the venous, all right, lock in before dumping into the circulatory system. Our final checkpoint. And remember, this is the final drainage point of 75% of the body, abdominal organs included. So if we have enlargement here, that typically is going to suggest some sort of abdominal malignancy. And again, I said it's a bit morbid. If swelling is occurring here and the malignancy is abdominal in nature, well, that means we have quite a bit of metastasis going on, and that's just never a good sign. So a big swelling here with malignancies downstream is a really, really bad sign. But it does, in a way, really hammer home the idea that, well, this is a final drainage point. So, yeah, yes, very bad if this area is swollen, but hopefully, the reason I bring up pathologies is when we figure out, well, what happens when things are wrong, it honestly reinforces the function, the proper function of these systems. So this being swollen, yeah, really bad, but why is it really bad? Well, because this is the final drainage point, right? So that cyclical reasoning there is really helpful, at least I think. Okay, so that's drainage pathways. That's 4.2. Thank you for your continued attention. Again, apologies for the delay in getting this one out. Thank you guys very much. Adios.